Acute or severe, it is unlikely that a patient is able to provide a detailed description of the entire experience. During an episode of acute pain, streamline your assessment and assess its location, severity, and quality. Collect a more detailed acute pain assessment when the patient is more comfortable. Box 44-5. For patients with chronic pain, a thorough pain assessment includes effective 10 and up. Box 44-5. Nursing assessment questions. Current pain, modify assessment for patient's age, cognitive ability, culture, language, and other factors. Palliative or provocative factors, what makes your pain worse? What makes it better? Quality, how do you describe your pain? Relief measures, what do you take at home to gain pain relief? Region, location, show me where you hurt. Severity, on a scale of 0 to 10, how bad is your pain now? What is the worst pain you have had in the past 24 hours? What is the average pain you have had in the past 24 hours? Timing, is your pain constant, intermittent, or both? Effect of pain, what are you not able to do because of your pain? With whom do you live, and how do they help you when you have pain? Current medications. Which medication/herbs are you taking now? Are these medications and herbs effective in relieving the pain? Which non-pharmacological treatments have you tried to relieve the pain? Which medications have you tried in the past that work to stop your pain? Have you ever used recreational drugs or alcohol to alleviate pain? Activity. What level of daily exercise can you maintain with your pain? Which type of movement increases or relieves your pain? Which type of activities do you now avoid because of your pain? Because pain is dynamic, accurate assessment requires you to monitor it on a regular basis along with other vital signs. Some institutions treat it as the fifth vital sign. Pain assessment is not simply a number. Relying solely on a number fails to capture the multidimensionality of pain and may be unsafe, particularly when the number fails to reflect the entire pain experience or when the patient does not understand the use of the selected pain rating scale. Pain assessment is a nursing function. However, nursing assistive personnel, NAP, physical therapists, social workers, and others also screen for pain by asking patients if they are having pain. When pain is noted by any care provider, it is essential that a nurse be informed immediately so he or she can make a thorough assessment to confirm the patient's discomfort and provide appropriate treatment.
So, if the nurse ain't the nurse caring for the patient ain't the one who ain't taking care of the patient, so like the physical therapist asks, do you have any pain? They say yes, they should tell the nurse immediately so they can take care of it.
Treatment. The ability to establish a nursing diagnosis, decide on appropriate interventions, and evaluate a patient's response, outcomes, to interventions depends on the fundamental activity of a factual, timely, accurate pain assessment, figure 44-4. The core of this complex activity is the exploration of the pain experience through the eyes of the patient. Nurses use a variety of tools to assess nociceptive and neuropathic pain. In selecting a tool to be used with a patient, be aware of the clinical usefulness, reliability, and validity of the tool in that specific patient population. For example, a tool that has been validated for use with preverbal children may not have validity or reliability for use with adults. Assessment tools, or scales, are available for use with a number of different patient populations, including critically ill adults, young 10-24 children, or adults with advanced dementia. The goal in using these tools is to identify how much pain exists, not to identify how much pain the patient tolerates. Figure 44-4 Critical Thinking Model for Pain Assessment. AHRQ, Agency for Healthcare Research and Quality, APS, American Pain Society, ESPM, American Society for Pain Management Nursing. It is necessary to be aware of possible errors in pain assessment, box 44-7. Using the right tools and methods helps to avoid errors and ensures the selection of the right pain interventions. Failure of clinicians to accurately assess a patient's pain, accept the findings, and treat the report is a common cause of unrelieved pain and suffering. Box 44-7. Possible sources for error in pain assessment. Bias, which causes nurses to consistently overestimate or underestimate the pain that patients experience. Vague or unclear assessment questions, which lead to unreliable assessment data. Use of pain assessment tools that are not evidence-based or validated in a particular patient population. Use of medical terms that patients with low health literacy cannot understand. Patients who do not always provide complete, relevant, and accurate pain information. Patients who are cognitively impaired and unable to use pain scales.
Okay, I think this is important. So, possible sources for error in pain. So, bias. This one is a big one. Vague or unclear assessment questions. So, like, if you don't ask it properly, if you just ask, like, vague stuff, it's not going to help. Pain assessment tools, just not proper assessment tools to use. So, like, I don't know, but just like medical terms. So you gotta look at their health literacy. Patients who do not provide complete, relevant, accurate pain information. Patients who are cognitively impaired can't use unable to use. You can use different things for them. I think that's important.
Patient's expression of pain. A patient's self-report of pain is the single most reliable indicator of its existence and intensity. APS, 2009, Paciro and McCaffrey, 2011. Pain is individualistic. Many patients fail to report or discuss discomfort. At the same time, many nurses believe that patients report pain if they have it. If patients sense that you doubt that pain exists, they share little information about their pain experience or minimize their report. A caring therapeutic relationship must be established with the patient that allows for open communication. Simple measures such as sitting when talking to patients about pain lets them know that you are sincerely concerned about their pain. Patients unable to communicate effectively often require special attention during assessment. Infants and children, people who are developmentally delayed, patients who are psychotic, the patient who is critically ill or at end of life, patients with dementia, and patients who are aphasic or do not speak English all require different approaches. Hare et al., 2011, examined various pain behavior assessment tools used with patients who were cognitively impaired. Although no one tool had sufficient reliability and validity, there are clinical practice recommendations, box 44-8. However, you need to understand that the number obtained when using a pain behavior scale is a pain behavior score, not a pain intensity rating. Paciro and McCaffrey, 2011. These tools identify the presence of pain but do not determine its intensity.
Okay, so pain tools say like, okay, there's pain there, but we don't really know how intense it is. Okay, I gotcha.
Patients with cognitive impairments often require insightful assessment approaches involving close observation of vocal response, facial movements, example grimacing, clenched teeth, and body movements, example restlessness, pacing. Also assess social interaction, example does the patient avoid conversation. Patients who are critically ill and have a clouded sensorium or the presence of nasogastric tubes or artificial airways require specific questions that they can answer with a nod of the head or by writing out a response. If the patient speaks a different language, pain assessment is difficult. A professional interpreter is often necessary. Paciro and McCaffrey.
This is important. This big assessment, so I'll come back over this in a bit. That's important.
McCaffrey, 2011. When a patient is in pain, conduct a focused physical and neurological examination and observe for nonverbal responses to pain, example grimacing, rigid body posture, limping, frowning, or crying. Paciro and McCaffrey, 2011. Examine the painful area to see if palpation or manipulation of the site increases pain. Characteristics of pain. Assessment of the characteristics of pain allows you to understand the type of pain, its pattern, and the types of interventions that bring relief. Use of instruments to quantify the extent and degree of pain depends on a patient being cognitively alert enough to be able to understand and follow instructions. Timing, onset, duration, and pattern. Ask questions to determine the onset, duration, and time sequence of pain. When did it begin? How long has it lasted? Does it occur at the same time each day? Is it intermittent, constant, or a combination? Combination. How often does it recur? It is sometimes easier to diagnose the nature of pain by identifying time factors. Knowing the time cycle or pattern of pain helps you intervene before the pain occurs or worsens. Location. Ask a patient to describe or point to all areas of discomfort to assess pain location. To localize the pain specifically, have him or her trace the area from the most severe point outward. This is difficult to do if pain is diffuse or involves several sites or parts of the body. Do not assume that your patient's pain always occurs in the same location. When describing pain location to other healthcare providers, use anatomical landmarks and descriptive terminology. The statement pain is localized in the upper right abdominal quadrant is more specific than the patient states the pain is in the abdomen. Pain classified by location is superficial or cutaneous, deep or visceral, referred, or radiating. Table 44-5. Table 44-5. Classification of pain by location. Location. Characteristics. Examples of causes. Superficial or cutaneous. Pain resulting from stimulation of skin. Pain is of short duration and localized. It usually is a sharp sensation. Needle stick, small cut or laceration. Deep or visceral. Pain resulting from stimulation of internal organs. Pain is diffuse and radiates in several directions. Duration varies, but it usually lasts longer than superficial pain. Pain is sharp, dull, or unique to organ involved. Crushing sensation, example angina pectoris, burning sensation, example gastric ulcer. Referred. Common in visceral pain because many organs themselves have no pain receptors, the entrance of sensory neurons from affected organ into same spinal cord segment as neurons from areas where individual feels pain causes perception of pain in unaffected areas. Pain is in part of body separate from source of pain and assumes any characteristic. Myocardial infarction, which causes referred pain to the jaw, left arm, and left shoulder. Kidney stones, which refer pain to groin. Radiating. Sensation of pain extending from initial site of injury to another body part. Pain feels as though it travels down or along body part. It is intermittent or constant. Low back pain from ruptured intravertebral disc accompanied by pain radiating down leg from sciatic nerve irritation.
Okay, I think this is important. The classification of pain by location. So, superficial cutaneous. Obviously, it's going to be in the skin. Short duration, localized, it's kind of sharp, like a small cut laceration or needle stick. But it's deep or visceral. It's going to affect the organs. The pain is affecting the internal organs. It's diffuse, and it could radiate in several directions. It lasts however long, usually longer than superficial. It's sharp, dull, or unique to you getting involved. So, like if it's crushing, it'd be like angina pectoris, and if it's burning, it'd be like gastric ulcer. Referred, it's like it's in part of the body separate from the source of pain and assumes any characteristic. Like MI, that's like affecting your heart, but you feel the pain in the jaw, left arm, left shoulder, kidney stones, stuff like that. And then radiating, it feels as though it's traveling down or along the body part, is intermittent or constant, so like low back pain from ruptured intervertebral disc accompanied by pain radiating down leg from sciatic nerve irritation.
Severity. One of the most subjective and therefore most useful characteristics for reporting pain is its severity. Nurses teach patients how to use pain scales to help them communicate pain severity or intensity. Many scales are available in several languages to aid nurses when a professional interpreter is not present. Passero and McCaffrey, 2011.
So is the most important pain characteristic severity? That's my question.
2011. The purpose of using a pain scale is to identify pain intensity over time so the effectiveness of interventions can be evaluated. Passero and McCaffrey, 2011. It is important to select the scale that is appropriate for a patient's age, language, and ability and to ensure that the patient understands how to use it. Examples of pain intensity scales include numerical rating scales, NRSs, verbal descriptor scales, VDSs, and visual analog scales, VAS. An NRS requires patients to rate pain on a line scale of 0 to 10, with 0 representing no pain and 10 representing the worst pain the patient can imagine. These scales work best when assessing pain intensity before and after therapeutic interventions. A VDS consists of a line with 3 to 6 word descriptors equally spaced along the line. Show a patient the scale and ask him or her to choose the descriptor that best represents the severity of pain. A VAS consists of a straight line without labeled subdivisions. The straight line shows a continuum of intensity and has labeled endpoints. A patient indicates pain by marking the appropriate point on the line. Use a scale to measure the current severity of a patient's pain. Also ask patients to rate their average pain and the worst pain they have had in the past 24 hours. This information allows you to see trends in pain severity. A good pain scale is easy to use, understandable, and not time-consuming. If a patient is able to read and understand a scale easily, the pain description is more accurate. If patients use a hearing aid or glasses, be sure that they are using them when answering pain assessment questions or marking a pain scale. Once you select a scale 1026 that works for a patient, be sure to use it consistently. Do not use a pain scale to compare the pain of one patient to that of another. Assessing pain intensity in children requires special techniques. Children's verbal statements are most important. Hockenberry and Wilson, 2015. Young children do not always know what the word pain means, therefore assessment requires you to use words such as ooey, boo-boo, or her. Some unique tools are available to measure pain intensity in children. FACES pain scales are commonly used, with 4 having undergone extensive psychometric testing for reliability and validity. FACES pain scale, FPS, scored 0 to 6, FACES pain scale revised, FPSR, 0 to 10, Oucher pain scale, 0 to 10, and Wong-Baker FACES pain rating scale, WBFPRS, 0 to 10, Tomlinson ETAL, 2010. The Oucher, Bayer ETAL, 1992, uses photographs of the face of a child, in increasing levels of discomfort, to cue children into understanding pain and its severity. A child points to a face on the tool, thus simplifying the task of describing the pain. There are cultural versions of the tool, figure 44-6. The WBFPRS, Wong and Baker, 1988, assesses pain in verbal children, figure 44-7. The scale consists of 6 cartoon faces ranging from a smiling face, no hurt, to increasingly less happy faces, to a final sad, tearful face, hurts worst. Children as young as 3 years of age use the scale. The FPS was adapted by the IASP in 2001 to facilitate a rating score from 0 to 10. This version, known as the FPSR, figure 44-8, has the advantage of not displaying emotions such as smiles or tears and may be used with children ages 4 to 16 years, IASP, 2014a. Nurses use a variety of other tools to assess pain in neonates, infants, nonverbal toddlers, and children with cognitive impairments. Figure 44-6 Asian girl. Quality. There is no common or specific pain vocabulary in general use. Patients describe pain in their own way. A study conducted in 1990 showed that Hispanics, American Indians, blacks, and whites all rated pain as the most intense term, followed by hurt. Ache was the least intense. Gaston Johansson et al., 1990. The research is dated, but at 1027 shows the importance of not assuming that one patient perceives pain differently than another only on the basis of...
I don't know if this is important, but you never know.
Basis of cultural background. Assess the terms that patients use to describe their discomfort and then always use these words consistently to obtain an accurate report. For example, say, "Tell me what your discomfort feels like." The patient may describe the pain as crushing, throbbing, sharp, or dull. For example, if it is dull, when you return to the patient, ask if it is still dull. It is always more accurate to have patients describe the pain in their own words whenever possible. There is some consistency in the way people describe certain types of pain. The pain associated with a myocardial infarction is often described as crushing or vice-like, whereas the pain of a surgical incision is often described as dull, aching, and throbbing, indicating nociceptive pain. Neuropathic pain is usually burning, shooting, or electric-like. Sadler, 2013. When a patient's descriptions fit the pattern forming in the assessment, you then make a clearer analysis of the nature and type of pain. This leads to more appropriate pain management because you treat nociceptive and neuropathic pain differently. Aggravating and precipitating factors. Various factors or conditions precipitate or aggravate pain. Ask a patient to describe activities that cause or aggravate pain such as physical movement, positions, drinking coffee or alcohol, urination, swallowing, eating food, or psychological stress. Also ask them to demonstrate actions that cause a painful response such as coughing or turning a certain way. Some symptoms, depression, anxiety, fatigue, sedation, anorexia, sleep disruption, spiritual distress, and guilt, cause worsening of pain or may be aggravated by it. Assess for these associated symptoms and evaluate their effects on the patient's pain perception. After identifying specific aggravating or precipitating factors, it is easier to plan interventions to avoid worsening the pain. Relief measures. It is useful to know whether a patient has an effective way of relieving pain such as changing position, using ritualistic behavior, pacing, rocking or rubbing, eating, meditating, praying, or applying heat or cold to the painful site. The patient's methods are ones that can often be used for treatment if appropriate to the cause of pain. Patients gain trust when they know that nurses are willing to try their relief measures. This is particularly the case in home settings. Patients gain a sense of control over the pain instead of the pain controlling them. Assessment of relieving factors also includes identification of all the patient's healthcare providers, example internist, orthopedist, acupuncturist, chiropractor, or dentist. Effects of pain on the patient. Pain alters a person's lifestyle and psychological well-being. For example, chronic/persistent pain causes suffering, loss of control, loneliness, exhaustion, and an impaired quality of life. To understand a pain experience, ask the patient what the pain prevents him or her from doing. Behavioral effects. When a patient has pain, assess verbalization, vocal response, facial and body movements, and social interaction. A verbal report of pain is a vital part of assessment. You need to be willing to listen and understand. When a patient is unable to communicate pain, it is especially important for you to be alert for behaviors that indicate it. Box 44-9.
So these are a bunch of things that you can use to behavioral indicators of effects of pain. So like vocalization, they might moan, cry, gasp, or grunt. Facial expressions like grimacing, clenching their teeth, foreheads wrinkled, tightly closed or wide open eyes or mouth, biting their lip. Body movement be restless, immobile, tense muscles, increased hand and finger movement, pacing activities, rhythmic or rubbing motions, protective motions of body parts. That's the biggest one I could see. Grabbing horny part, right? Okay, those two. And social interaction, avoidance of conversation, focus only on activities for pain relief, avoid social contacts, reduce attention span, reduce interaction with the environment. Those are some things.
The nonverbal expression of pain either supports or contradicts other information about it. If a woman in labor reports that her labor pains are occurring more frequently and if she begins to massage her abdomen more often, this confirms her report. If a patient reports severe abdominal pain but continues to grasp the chest, a more detailed assessment is likely needed. Influence on activities of daily living. Patients who live with daily pain or have prolonged pain during a hospitalization are less able to participate in routine activities, which results in physical deconditioning. This deconditioning can slow recovery of hospitalized patients. Assessment of these changes reveals the extent of the patient's disabilities and adjustments necessary to help them participate in self-care. The primary goal of the nurse is to improve patient function. Ask a patient whether pain interferes with sleep. Some patients experience difficulty in falling asleep and/or staying asleep. The pain may awaken the patient during the night and make it hard to fall back 10:28 to sleep. Consider giving medications or trying non-pharmacological interventions to promote sleep. See Chapter 43. Patients should be instructed not to use pain medications for the purpose of sleep promotion, and they should not use medications that promote sleep as a substitute for pain relief.
Right.
Depending on the location of the pain, some patients have difficulty independently performing ADLS. For example, some pain restricts mobility to the point at which a patient is no longer able to bathe in a bathtub or dress himself or herself. Patients with severe arthritis find it painful to grasp eating utensils or lower themselves to a toilet seat. Assess the patient's need for help with self-care activities, determine if a family caregiver provides assistance at home, and collaborate with members of the healthcare team, example physical and occupational therapy. Pain sometimes impairs the ability to maintain normal sexual relations. Physical conditions such as arthritis or back pain may prevent patients from assuming usual positions during intercourse. Pain or fatigue may reduce a patient's desire for sex. An assessment should include the extent to which pain affects the patient's usual sexual activity, i.e., physically unable or reduced desire. Pain threatens a person's ability to work. The more physical activity required in a job, the greater the risk of discomfort when the pain is associated with movement. Pain related to emotional stress increases in individuals whose jobs involve stressful decision-making. Assess the work that patients do and their abilities to function in their jobs. Assess the daily chores of homemakers in the same manner as the duties involved in jobs outside the home. Also assess whether it is necessary for patients to stop activity occasionally because of pain and help them select ways to minimize or control it so they are able to remain productive. Include an assessment of the effect of pain on social activities. Some pain is so debilitating that the patient becomes too exhausted to socialize. Identify a patient's normal social activities, the extent to which activities have been disrupted, and the desire to participate in these activities. Concomitant symptoms. Concomitant symptoms, including nausea, headache, dizziness, urge to urinate, constipation, depression and restlessness, occur with pain and usually increase a patient's pain severity. Certain types of pain have predictable concomitant symptoms. For example, severe rectal pain often leads to constipation. These symptoms are as much a problem to a patient as the pain itself. Nursing diagnosis. An accurate nursing diagnosis may be made only after you perform a complete assessment. The development of accurate nursing diagnoses for a patient in pain results from thorough data collection and analysis, box 44-10. Careful assessment reveals the presence or potential for pain. Be sure that your assessment includes the patient's history of recent procedures or pre-existing painful conditions. Box 44-10. Nursing diagnostic process. Chronic pain. Assessment activities. Defining characteristics. The nursing diagnosis focuses on the specific nature of a patient's pain to identify the most useful types of interventions for alleviating it and improving the patient's function. Acute pain related to physical trauma and acute pain related to natural childbirth processes require very different nursing interventions. Accurate identification of related factors is necessary in choosing appropriate nursing interventions. For example, interventions for acute pain related to physical trauma usually require pharmacological intervention, whereas acute pain related to natural childbirth processes is sometimes managed more appropriately with non-pharmacological interventions such as controlled breathing techniques. A pain assessment often directs you to identify additional diagnoses other than that of acute or chronic pain. The extent to which pain affects a patient's function and general state of health determines whether other nursing diagnoses are relevant. For example, your assessment reveals that a patient reports having pain of the hands and shoulders and has difficulty removing or fastening necessary items of clothing. The patient has had osteoarthritis for over 3 years with persistent discomfort and weakness of the upper extremities. The nursing diagnoses for this patient are dressing self-care deficit and chronic pain. The diagnosis of dressing self-care deficit requires involvement by members of the interdisciplinary healthcare team to provide the patient with assistive devices for performing self-care. Examples of other diagnoses that may be related to pain follow. Activity intolerance. Anxiety. Bathing self-care deficit. Ineffective coping. Fatigue. Impaired physical mobility. Insomnia. Impaired social interaction. Planning. During the planning step of the nursing process, analyze information from multiple sources. Critical thinking ensures that a patient's plan of care, see the nursing care plan, integrates all that is known about the individual and key critical thinking elements, figure 44-9. Professional standards are especially important to consider when developing a plan of care. These standards establish evidence-based guidelines for selecting effective nursing interventions. Professional standards of care regarding pain management are available as agency policies or through professional organizations such as the American Society for Pain Management Nursing, ASPN. Nursing care plan. Acute pain. Assessment. Mrs. Mays, 72 years old, was diagnosed with a cancerous tumor in her left lung 2 months ago. She also has a history of osteoarthritis, which was diagnosed 8 years ago. The arthritis causes chronic inflammation with mild to moderate pain in the joints of her hands and wrists that affects her daily. After chemotherapy and radiation therapy, she took ibuprofen, Advil, 200 mg on an as needed. Another strategy for planning care is using a concept map. Patients who are in pain frequently have interrelated problems. As one problem gets worse, other aspects of a patient's level of health also change. A concept map helps you determine how the nursing diagnoses are interrelated with one another and linked to the patient's medical diagnosis. This eventually allows you to also see how interventions are related for different diagnoses. Using the example for Mrs. Mays, the patient with osteoarthritis, note the relationships among acute pain, impaired physical mobility, dressing and feeding self-care deficit, and fatigue, figure 44-10. Identifying these relationships helps you develop a holistic and patient-centered plan of care. Figure 44-10 concept map for Mrs. Mays. ATC 1029. Goals and outcomes. When managing pain, goals of care promote a patient's optimal function. Along with the patient, determine the realistic expectations for pain relief. Decide on a mutually acceptable level of pain that allows return of function. Make sure that the patient understands that complete pain relief is probably not possible, but that every effort will be made to allow him or her to safely reach a pain level that allows for maximum function. It is important to remember that a successful plan of care requires a therapeutic relationship with the patient and family to focus on a relevant education plan. Helping patients learn how to manage their pain is always a goal of care. You help best by listening to the patient's concerns, needs, and understanding of available pain relief measures. A patient knows the most about his or her pain and is an important partner in selecting successful pain therapies. An indication of the success of a plan of care is determined through attainment of goals and outcomes. For example, for the goal the patient will achieve a satisfactory level of pain relief within 24 hours, the following are possible outcomes. Reports that pain is a 3 or less on a scale of 0 to 10. Avoids factors that intensify pain. Uses pain relief measures safely. Level of discomfort does not interfere with dressing self. Setting priorities. When setting priorities in pain management, consider the type of pain the patient is experiencing and the effect that it has on various body functions. Work with the patient to select interventions that are appropriate. For example, if an analgesic is relieving acute pain, turn your attention to how the pain is affecting the patient's activity, appetite, and sleep. In contrast, when a patient's pain continues to be severe, preventing implementation of other interventions, immediate pain relief is the obvious priority. Priorities change as a patient's pain experience changes. Teamwork and collaboration. A comprehensive plan includes a variety of resources from the healthcare team such as advanced practice nurses, doctors of pharmacology, PharmDs, physical therapists, occupational therapists, physicians, social workers, psychologists, and clergy. An oncology or pain clinical nurse specialist is very familiar with pharmacological and non-pharmacological interventions that are most effective for chronic/persistent pain. PharmDs are knowledgeable about pharmacological treatments of pain. Physical therapists plan exercises that strengthen muscle groups and lessen pain in affected areas. Occupational therapists devise splints to support painful body parts. Physicians are familiar with pharmacological interventions, and some are skilled in interventional pain procedures such as nerve blocks and spinal cord stimulator implantations. Social workers and psychologists may offer non-pharmacological approaches to pain management such as cognitive behavioral therapy or mindfulness training. Clergy members help patients focus on spiritual health. It is important to also involve family caregivers in the plan of care. They will often administer care in the home after discharge. If the pain management plan is not successful in achieving the identified pain relief goal, talk with the patient's healthcare provider about revising it. Consultation with a pain expert is sometimes necessary. Implementation. Pain therapy requires an individualized approach, perhaps more so than any other patient problem. The nurse, patient, and frequently the family are partners in pain management. You are responsible for administering and monitoring therapies ordered by healthcare providers for pain relief and independently providing measures that complement those prescribed. Generally try the least invasive or safest therapy first along with previously used successful patient remedies. If you question a medical therapy, consult with the healthcare provider. Regardless of the therapies chosen, your ability to show compassionate care toward patients has the potential for maximizing their pain control. You can help the patient minimize pain through caring behaviors such as listening, offering a gentle touch, and responding promptly to a pain request. 1031. Health promotion. When providing pain relief measures, choose therapies suited to a patient's unique pain experience. Apply guidelines for individualizing pain therapy, including the following. Use different types of pain relief measures. Use measures that patient believes are effective. Keep an open mind about ways to relieve pain. Keep trying. When efforts at pain relief fail, do not abandon the patient but reassess the situation. Maintaining wellness. Patients are better prepared to handle almost any situation when they understand it. The experience of pain and related therapies are no exception. However, patients with moderate to severe pain are not always able to participate in decision-making until the pain is controlled at an acceptable level. Once you accomplish this, you can begin teaching. Health literacy significantly affects a patient's pain experience and understanding of pain management strategies. Low health literacy poses significant barriers to optimal pain management. In a study of patients with chronic pain, patients with low health literacy were found to have low overall pain medication knowledge and did not know where to find healthcare professionals to help them with their pain. Deverage et al., 2013. The patients in the study also lacked knowledge about non-pharmacological approaches to pain management and did not know which non-prescription pain medications could provide pain relief. Research conducted with patients with chronic back pain and other patient groups provides evidence for why educational materials and approaches must be adapted so they are suited for low health literacy patients. In addition, combat any cultural norms that may stop patients from talking about pain at all. Stoicism not only potentially obscures dangerous signs about which you should know, but it also denies people the opportunity to use labels as a tool to cope with pain. Help patients who don't have the words to describe their pain find them. Booker, 2014. Because pain affects physical and mental functioning, holistic health approaches are important interventions for maintaining wellness. Holistic health is an ongoing state of wellness that involves taking care of the whole person, body, mind, spirit, and emotions. To achieve optimal health and well-being, it is necessary to have balance of all of the interdependent elements of the whole person. Matthews Kozenekot, 2014. Patients actively participate in their own well-being whenever possible. Common holistic health approaches include wellness education, regular exercise, rest, attention to good hygiene practices and nutrition, and management of interpersonal relationships. When a person develops pain, you can offer non-pharmacological and pharmacological strategies. Several non-pharmacological interventions are nurse-initiated. Non-pharmacological pain relief interventions. A number of non-pharmacological interventions are available for lessening pain. However, more research is needed to truly know the best approach, intensity, duration, and content of these interventions, especially for the treatment of chronic pain. Park and Hughes, 2012. The researchers suggest that non-pharmacological interventions may be useful for patients who cannot tolerate pain medications, those who wish to reduce multiple medications, and those who are seeking alternative methods of relieving chronic pain. Non-pharmacological interventions can be used alone or in combination with pharmacological measures. However, in the case of acute pain, they should never be used in place of pharmacological therapies. Non-pharmacological interventions include cognitive behavioral and physical approaches. Cognitive behavioral interventions change patients' perceptions of pain, alter pain behavior, and provide patients with a greater sense of control. Distraction, prayer, relaxation, guided imagery, music, and biofeedback are examples. Physical approaches aim to provide pain relief, correct physical dysfunction, alter physiological responses, and reduce fears associated with pain-related immobility. Complementary and alternative medicine, CAM, therapies such as therapeutic touch and mindfulness meditation help to alleviate pain in some patients, see Chapter 33. An evidence-based practice protocol for pain management in older 1032 adults recommends these guidelines for non-pharmacological therapies, Horgas et al., 2012. Tailor non-pharmacological techniques to the individual. Cognitive behavioral strategies may not be appropriate for the cognitively impaired. Physical pain relief strategies focus on promoting comfort and altering physiological responses to pain and are generally safe and effective. Relaxation and guided imagery. Relaxation and guided imagery allow patients to alter effective motivational and cognitive pain perception. Relaxation is mental and physical freedom from tension or stress that provides individuals a sense of self-control. You use relaxation techniques at any phase of health or illness. Physiological and behavioral changes associated with relaxation include the following: decreased pulse, blood pressure, and respirations, heightened awareness, decreased oxygen consumption, a sense of peace, and decreased muscle tension and metabolic rate. Topku and Feindick, 2012. Relaxation techniques include meditation, yoga, Zen, guided imagery, and progressive relaxation exercises. See Chapter 33. For effective relaxation, teach techniques only when a patient is not distracted by 1033 acute discomfort. Sometimes a combination of these techniques is needed to achieve optimal pain relief. With practice, the patient performs relaxation exercises independently. Distraction. The reticular activating system inhibits painful stimuli if a person receives sufficient or excessive sensory input. With sufficient sensory stimuli, a person ignores or becomes unaware of pain. People who are bored or in isolation have only their pain to think about and thus perceive it more acutely. Distraction directs a patient's attention to something other than pain and thus reduces awareness of it. A disadvantage of distraction is that, if it works, healthcare providers or family members may question the existence or severity of the pain. Distraction works best for short, intense pain lasting a few minutes, such as during an invasive procedure or while waiting for an analgesic to work. Use activities enjoyed by the patient as distractions, example singing, praying, listening to music, or playing games. Music. Music therapy may be useful in treating acute or chronic pain, stress, anxiety, and depression. Already et al., 2010, Korhan et al., 2014. It diverts a person's attention away from the pain and creates a relaxation response. Music creates positive changes in mood and emotional states and allows patients to actively participate in treatment. Music therapy uses all kinds of music. It is important to let patients select the type of music they prefer. Music produces an altered state of consciousness through sound, silence, space, and time. Therapeutic sessions usually last 20 to 30 minutes. Hughes, 2008. Patients may use earphones to enhance their concentration on the music. This allows them to adjust the volume without interrupting other patients or staff. Evidence shows that music contributes to the pain relief of hospitalized patients and may decrease the use of analgesics in some postoperative patients. Cole and Lobian DeWood, 2014. Cutaneous stimulation. Stimulation of the skin through a massage, warm bath, cold application, and transcutaneous electrical nerve stimulation, TENS, may be helpful in reducing pain perception. How cutaneous stimulation works is unclear. One suggestion is that it causes release of endorphins, thus blocking the transmission of painful stimuli. The gate control theory suggests that cutaneous stimulation activates larger, faster transmitting A-beta sensory nerve fibers. This closes the gate, thus decreasing pain transmission through small diameter C fibers, Meltsack and Wall, 1965. Cutaneous stimulation gives patients and families some control over pain symptoms and treatment in the home. Using it properly helps to reduce muscle tension, resulting in less pain. When using cutaneous stimulation, eliminate sources of environmental noise, help the patient to assume a comfortable position, and explain the purpose of the therapy. Do not use it directly on sensitive skin areas, example burns, bruises, skin rashes, inflammation, and underlying bone fractures. Massage is effective for producing physical and mental relaxation, reducing pain, and enhancing the effectiveness of pain medication. Massaging the back, shoulders, hands, and / or feet for 3 to 5 minutes relaxes muscles and promotes sleep and comfort. Kuchal et al., 2010, reported a significant decrease in pain, anxiety, and tension in patients with cardiac problems who received a 20-minute massage. In older adults, low back massage and a 20-minute hand massage improved pain, anxiety, tension, and insomnia. Harris and Richards, 2010. Massages communicate caring and are easy for family members or other healthcare personnel to learn. Box 44-11. Box 44-11.
After performing hand hygiene and ensuring privacy, introduce yourself to the patient. Then identify the patient using 2 identifiers.
Hi, Mr. Tabor. My name's Bobby. I'm your nurse today. How are you doing today?
Not so good.
Not so good? I'm going to check your name and take your pulse, and then we'll see what we can do about your pain. Okay? Can you confirm your full name for me?
James Tabor.
And your birthday.
7/6/51.
Great.
Back massage is a welcome form of non-pharmacologic pain relief for many patients. To give your patient a back rub, begin by assessing his level of pain or discomfort.
Okay. And tell me where you're doing how you're doing on a pain scale. Between 0 and 10, 10 being the worst.
6.
About a 6?
6, yeah.
I'd like to do a back
Offer him an analgesic before giving the back rub to make him more comfortable during the procedure.
Does that sound okay?
That would be great.
I'm going to step out and get some supplies, and I'll be right back.
Okay.
Okay. How's the temperature feel in here for you?
Prepare the patient's environment by adjusting the room temperature and lighting.
Seems okay?
That's good.
Great. Okay, move the bed up a little bit.
Be sure to adjust the bed to a position that's comfortable for you by lowering the upper rail on your side.
The head down.
Help your patient find a comfortable position, either prone or on his side. If he has trouble breathing, help him lie on the side of the bed with the head of the bed elevated. Ask the patient if he'd like a little background music to help him relax. If so, let him decide what he feels like listening to.
Back out a little bit. There you go. Would you like any music on?
No, thank you.
And do you have any allergies to any lotions?
No.
Ask the patient if he's allergic to the lotion you're using. Untie the patient's gown and drape the patient with a folded sheet, exposing only the areas to be massaged. Assess the skin and apply gloves if necessary. Warm the lotion in your hands. During a bath, the lotion can be warmed in a basin of water. Plan to use a variety of strokes depending on what type of pain your patient has. Effleurage is a technique in which a gliding stroke is used to massage upward and outward from the vertebral column and back again. This motion doesn't manipulate deep muscles, but smooths and extends them, increasing nutrient absorption and improving lymphatic and venous circulation. Petrissage is a kneading motion used to relax tense muscle groups and stimulate local circulation. Friction is accomplished by using strong circular strokes to bring blood close to the surface of the skin, increase local circulation, and loosen tight muscle groups. As you work, encourage the lotion can be worn the patient has.
All right, that's all we care about right here.
Cold and heat applications, see Chapter 48, relieve pain and promote healing. The selection of heat versus cold interventions varies with patient's conditions, Guild, 2012. For example, moist heat helps to relieve the pain from a tension headache, and cold applications reduce the acute pain from inflamed joints. When using any form of heat or cold application, instruct the patient to avoid injury to the skin by checking the temperature and not applying cold or heat directly to the skin. Especially at risk for injury are patients with diabetic neuropathies, spinal cord, or other neurological disorders, older adults, and patients who are confused. Cold therapies are particularly effective for acute pain relief. Ice massage involves the use of a large ice cube or a small paper cup filled with water and frozen. Water rises out of the cup as it freezes to create a smooth surface of ice for massage. A nurse or the patient applies the ice with firm pressure to the skin, which is covered with a lightweight cloth. Then use a slow, steady, circular massage over the area. Apply cold within a 6-inch circular area near the pain site or on the opposite side of the body corresponding to the pain site. Limit application to 5 minutes or when the patient feels numbness. Spine Health, 2006. Each patient responds differently to the site of application. Application near the actual site of pain tends to work best. A patient feels cold, burning, and aching sensations and numbness. You can apply ice 2 to 5 times a day. Spine Health, 2006. Cold is effective for tooth or mouth pain when you place the ice on the web of the hand between the thumb and index finger. This point on the hand is an acupressure point that influences nerve pathways to the face and head. Cold applications are also effective before invasive needle punctures. Heat application is more effective for some patients, especially those with chronic pain. Chapter 48 discusses in detail the type of heat devices, example warm compresses and commercial heat packs, that are safe to use. Never place a heat application in a microwave unless it is directed by the manufacturer. Then follow directions carefully. Teach patients to check the temperature of the compress carefully and not to lie on the heating element because burning can occur. Another form of cutaneous stimulation is TENS, involving stimulation of the skin with a mild electrical current passed through external electrodes. A TENS unit consists of a battery-powered transmitter, lead wires, and electrodes. TENS works both peripherally and centrally. Centrally it acts by activating sites in the spinal cord and brainstem that use opioid and serotonin receptors. Peripherally neuroreceptors at the site of the TENS application produce analgesia. Descriptive 2008. It can be applied at various frequencies, 50 Hz, and intensity. Sensory versus motor. Descriptive 2008. Stimulation intensity has been shown to be the critical factor in TENS efficacy. A TENS unit requires a healthcare provider's order that identifies the site for the TENS electrode placement. Remove any hair or skin preparations before attaching the electrodes. Then place the electrodes directly over or near the pain site. Turn the transmitter onto the ordered level when the patient feels pain. The TENS creates a buzzing or tingling sensation. After assessing the patient's tolerance, he or she can then turn on the transmitter and adjust the intensity and quality of skin stimulation until pain relief occurs. TENS is effective for acute, emergent, and post-surgical and procedural pain control. Descriptive 2008. Herbals. Many patients use herbals and dietary supplements such as echinacea, ginseng, ginkgo biloba, and garlic despite conflicting research evidence supporting their use in pain relief. Significant attention has been paid to the potential benefits of glucosamine and chondroitin in the treatment of osteoarthritis, but the evidence is inconclusive. Falad Bakshir, 2012. Herbal supplements may interact with prescribed analgesics, thus it is important to ask patients to report to their healthcare provider all of the substances they take to relieve pain. See Chapter 33. Reducing pain perception and reception. One simple way to promote comfort is to remove or prevent painful stimuli. Box 44-12. This is especially important for patients who are immobilized or have difficulty expressing themselves. For example, your patient becomes constipated and has abdominal distension and cramping. You should 1035 intervene to ensure that the normal elimination process continues, increasing fluids, ambulating the patient, and or requesting stool softeners or laxatives. Another example involves reducing pain perception during procedures using techniques such as proper patient positioning and coaching to perform progressive muscle relaxation. Always consider the patient's condition, aspects of the procedure that are uncomfortable, and techniques to avoid causing pain. In a patient with severe arthritic knee pain who has severe discomfort during any extreme flexion of the knee, take precautions before walking the patient to the bathroom. Use an elevated toilet seat to allow him or her to sit and rise with minimal discomfort. Box 44-12. Controlling painful stimuli in patient's environment. Tighten and smooth wrinkled bed linen. Reposition patient anatomically to relieve any pressure points. Reposition patient to avoid lying on tubing, example intravenous tubing, chest tubes. Loosen constricting bandages, unless specifically applied as a pressure dressing. Change wet dressings and linens. Position patient in anatomical alignment according to individual preference or requirements. Check temperature of hot or cold applications, including bath water. Lift patient in bed, do not pull. Use safe patient handling lift devices. Position patient correctly on a bedpan. Avoid exposing skin or mucous membranes to irritants, example urine, stool, wound drainage. Keep patients clean, dry, and turned if needed. Use urinary incontinence pads if indicated. Prevent urinary retention by keeping Foley catheters patent and free-flowing if in use, while also monitoring urinary output. Prevent constipation with fluids, diet, exercise, and stimulant laxatives if needed.
I think these are important. These are some ways to control the stimuli in the environment. We'll go over these a bit later. Can you get your crap together? There we go.
Needed. Acute care. Nurses often care for patients who have acute pain resulting from invasive procedures, example surgery or trauma. Many professional organizations such as the APS, American Society of Anesthesiologists, ASA, and the American Society of Perianesthesia Nurses, ASPEN, have published guidelines and position papers related to acute pain management. The key to success is ongoing pain assessment and evaluation of the efficacy of interventions. Does the patient feel relief? Are there any unacceptable side effects from the medications? It is the responsibility of the healthcare team to collaborate to find a combination of therapy that works best for a patient. Pharmacological pain therapies. Many pharmacological agents are available to provide pain relief. Your judgment in the use and management of analgesics with or without other pain therapies ensures the best pain relief possible. Unfortunately, the ideal analgesic, i.e., one that provides highly effective pain relief without significant risks or side effects, has yet to be developed. Analgesics. Analgesics are the most common and effective method of pain relief. However, healthcare providers and nurses still tend to undertreat patients because of insufficient knowledge about pain management, incorrect drug information, concerns about addiction, exaggerated concerns about opioid analgesic safety, and administration of less medication than was ordered. Darcy, 2008, Gordon et al., 2008. You need to understand the medications available for pain relief, their indications for use, and their pharmacological effects. Reassure patients that treatment of pain is necessary to aid recovery and that addiction is highly unlikely when analgesics are taken correctly. There are 3 types of analgesics. 1. Non-opioids, including acetaminophen and nonsteroidal anti-inflammatory drugs, NSAIDs. 2. Opioids, traditionally called narcotics. And 3. Adjuvants or co-analgesics, a variety of medications that enhance analgesics or have analgesic properties that were originally unknown. Passero and McCaffrey, 2011. Acetaminophen, Tylenol, considered one of the most tolerated and safest analgesics available, is available in a variety of over-the-counter, OTC, oral medications, example cold and flu remedies, or rectal forms and in an intravenous, 4, preparation, Effleurage. The analgesic effect of acetaminophen is not entirely clear, but it is believed to have a direct effect on the central nervous system. It has no anti-inflammatory effects. 4. Acetaminophen, Effleurage, is an effective analgesic agent because it crosses the blood-brain barrier rapidly, thus providing non-opioid analgesia for postoperative patients, especially those who cannot take oral medications. The maximum 24-hour dose is 4g, the same limitation as aspirin. Acetaminophen is often combined with opioids, example oxycodone Percocet, hydrocodone Lortab, tramadol Ultracet, because it reduces the dose of opioid needed to achieve successful pain control. When acetaminophen is combined with an opioid in these products, it is important to recognize the abbreviations that describe the contents of the product. The order and package label often state name of opioid/acetaminophen, abbreviated as APAP, 5/325, which means that the opioid is 5 mg and the acetaminophen, APAP, is 325 mg per tablet. For example, oxycodone/APAP 5/325 indicates that each tablet contains 5 mg of oxycodone and 325 mg of acetaminophen. Similar abbreviations are used for combination products of hydrocodone and tramadol. The major adverse effect of acetaminophen is hepatotoxicity, and, because the drug is so widely used, the Food and Drug Administration, USFDA, 2014, issued an order to limit the amount of acetaminophen in prescription combination products to 325 mg per tablet, capsule, or other dosage unit. Instructions for acetaminophen containing products such as 1 to 2 tablets every 4 to 6 hours were not required to change in the order. Higher dosing units continue to be available in OTC products, but the products are required to include dosage labeling information about safety risks, including liver injury and the risks of serious skin rashes. Although some manufacturers have voluntarily reduced the maximum daily acetaminophen dose labeling on their OTC products, the FDA has not reduced the maximum daily dose limit of 4g for adults. Reduced doses are necessary for inadequate liver function and are recommended to prevent accidental overdose in the outpatient setting. It is important to read and understand these warning labels. Dangerous hepatotoxic overdoses of acetaminophen are treated with acetylcysteine, Mucomyst, Paciro and McCaffrey, 2011. Non-selective NSAIDs such as aspirin, ibuprofen, and naproxen relieve mild to moderate acute intermittent pain such as that from headache or muscle strain. Treatment of mild to moderate postoperative pain begins with an NSAID unless contraindicated, Paciro and McCaffrey, 2011. NSAIDs likely act by inhibiting the synthesis of prostaglandins, Day and Graham, 2013, and thus inhibit cellular responses to inflammation. Most NSAIDs act on peripheral nerve receptors to reduce transmission of pain stimuli and inflammation. Unlike opioids, NSAIDs do not depress the central nervous system, nor do they interfere with bowel or bladder function, Paciro and McCaffrey, 2011. However, NSAID use in the older patient is not recommended because it is associated with more frequent adverse effects, gastrointestinal bleeding and renal insufficiency, AGS, 2009. Mild to moderate musculoskeletal pain in older adults is managed effectively with acetaminophen, AGS, 2009, Paciro and McCaffrey, 2011. Some patients with asthma or an allergy to aspirin are also allergic to other NSAIDs, Morales et al., 2015. As with all OTC medications, patients should be advised to discuss their use of NSAIDs and their pain with their healthcare provider. Opioid or opioid-like analgesics are prescribed for moderate to severe pain. These analgesics act on higher centers of the brain and spinal cord by binding with opiate receptors to modify perceptions of pain. Examples of opioids include morphine, codeine, hydromorphone, dilaudid, fentanyl, oxycodone, and hydrocodone, Vicodin, Lortab. Some are available in 4 and oral preparations, morphine and hydromorphone, whereas others are only available in oral formulations, oxycodone and hydrocodone. Most are available in a short-acting form, which provides relief for about 4 hours. Some are also available in longer-acting preparations, oral morphine, oxycodone, hydromorphone, and a transdermal fentanyl patch. Opioids can cause numerous common side effects, box 44-13. Except for constipation and central nervous system changes, patients usually become tolerant to many of them. Other side effects associated with long-term use include depression, impaired sleep patterns, endocrine effects, decreased testosterone levels, decreased libido, and immune system suppression. To reduce side effects, patients should take the lowest dose of an opioid needed to manage pain. For example, if the prescriber initially ordered oxycodone 10 mg per every 4 hours and the patient has nausea and is very drowsy, the nurse might suggest 1036 that the prescriber reduce the dose to 5 mg. After administration, reassess a patient for the effect of the lowered dose on pain level and side effects. If reducing a dose does not relieve a side effect, confer with the prescriber about a change in the type of opioid. If side effects persist, it may be necessary to prevent or treat them by administering other medications, antihistamines, antiemetics, stimulants. Constipation should always be anticipated and prevented through diet, hydration, and the use of stool softeners and stimulants as needed. A rare adverse effect. Effect of opioids in opioid-naive patients, patients who have used opioid around the clock, ATC, less than approximately 1 week, is respiratory depression. Respiratory depression is only clinically significant if there is a decrease in the rate and depth of respirations from a patient's baseline assessment, Paciro and McCaffrey, 2011. All patients who receive opioids are at risk, but patients who are opioid-naive, new or restarting opioids, are at greater risk than those who have been taking them daily on a regular basis, TJC, 2012. It is important for nurses to obtain a complete opioid medication history, including dose, frequency, and duration of use to determine whether patients are opioid naive or tolerant. Patients who breathe deeply rarely have clinical respiratory depression. Sedation always occurs before respiratory depression. Closely monitor for sedation in opioid naive patients, Paciro and McCaffrey, 2011. If an adult patient experiences respiratory depression, administer naloxone, Narcan, 0.4 mg diluted with 9 ml saline, 4 push, IVP, at a rate of 0.5 ml every 2 minutes until the respiratory rate is greater than 8 breaths/min with good depth, Paciro and McCaffrey, 2011. Administering naloxone faster than recommended may cause severe pain and serious complications such as hypotension and hypertension, cardiac arrhythmias, dyspnea, and pulmonary edema, Paciro and McCaffrey, 2011. Evaluate patients who receive naloxone every 15 minutes for 2 hours following drug administration because its duration may be less than that of the opioid, and respiratory depression sometimes returns. One way to maximize pain relief while potentially decreasing opioid use is to administer analgesics ATC rather than a PRN basis. This approach ensures a more constant therapeutic blood level of an analgesic. The APS, 2009, supports ATC administration if pain is anticipated for the majority of the day. There are also a variety of extended or controlled release oral opioid formulations, dosing intervals of 8, 10, 12, or 24 hours, and transdermal patches, 72 hours. These formulations maintain constant serum opioid concentration, minimizing toxic and subtherapeutic concentrations, Burcham and Rosenthal, 2016. An ATC medication lessens the severity of end-of-dose pain, allowing a patient to sleep through the night and reduce clock watching for the next dose. Careful assessment and critical thinking are required to safely administer analgesics, box 44-14. The current pharmacological approach to acute and chronic pain management is to provide multimodal analgesia. Multimodal analgesia combines drugs with at least 2 different mechanisms of action so pain control can be optimized. Medications are combined to target different sites in the peripheral or central pain pathways, figure 44-11. A main benefit of multimodal analgesia is that the use of different agents allows for lower than usual 1037 doses of each medication, therefore lowering the risk of side effects while providing pain relief that is as good as or even better than could be obtained from each of the medications alone. Box 44-14. Nursing principles for administering analgesics. Know patient's previous response to analgesics. Determine whether patient has allergies. Know whether patient is at risk for using NSAIDs, example history of GI bleeding or renal insufficiency, or opioids, example history of obstructive or central sleep apnea. Identify previous doses and routes of analgesic administration to avoid undertreatment. Determine whether patient obtained relief. Ask whether a non-opioid was as effective as an opioid. Select proper medications when more than one is ordered. Use non-opioid analgesics or opioid combination drugs for mild to moderate pain. Give opioids with non-opioids to provide a multimodal analgesia approach. Avoid using multiple opioids with the same duration and mechanism of action. Intravenous medications act more quickly and usually relieve severe, acute pain within 1 hour, whereas oral medications take as long as 2 hours to relieve pain. Avoid intramuscular analgesics, especially in older adults. Use an opioid with a non-opioid analgesic for severe pain because such combinations treat pain peripherally and centrally. For chronic pain, give sustained release oral formulations ATC. No accurate dosage. Recall that 4G is considered the maximum 24-hour dosage for acetaminophen and acetyl salicylic acid, ASA, 3,200 mg for ibuprofen. Adjust doses as appropriate for children and older patients. Large doses of opioids are acceptable in opioid-tolerant patients but not in opioid-naive patients. When titrating opioid, it is important to titrate to effect or to uncontrollable side effects. Assess right time and interval for administration. Administer analgesics as soon as pain occurs and before it increases in severity. An ATC administration schedule is usually best. Give analgesics before pain-producing procedures or activities. Know the average duration of action for a drug and the time of administration so the peak effect occurs when the pain is most intense. Use extended-release opioid formulations to treat chronic pain. Avoid stopping opioids abruptly in patients who are opioid tolerant. ATC, around the clock, GI, gastrointestinal, NSAIDs, nonsteroidal anti-inflammatory drugs. Modified from Paciro, C. A person's response to an analgesic is highly individualized. If the pain is caused by inflammation, an NSAID is sometimes as effective as, or more effective than, an opioid. An orally administered analgesic usually has a longer onset and duration of action than an injectable form. In addition, for pain that persists for most of the day, controlled or extended-release opioid formulations, morphine MS-Contin, Codeine, Avanzat, oxycodone OxyContin, and methadone, are available for administration every 8 to 12 hours ATC, they are not ordered PRN. When you convert a patient from an 4 to an oral form of the same opioid, understand that the dose of the oral opioid is usually much higher than the 4 dose because of the first pass effect, Paciro and McCaffrey, 2011. When a patient takes oral opioids, the opioid first goes to the liver, where most, but not all, of the medication is inactivated. Thus the body needs larger doses of oral opioids to achieve the same level of pain relief as with 4 opioids. Know the comparative potencies of analgesics in oral and injectable form. In addition, know the route of administration most effective for a patient so controlled, sustained pain relief is achieved. The intramuscular, IM, route for analgesic administration should not be used because the IM injection is painful and drug absorption is inconsistent and erratic, Paciro and McCaffrey, 2011. When comparing opioids, equianalgesic charts, i.e., charts converting one opioid to another or parenteral forms of opioids, example morphine to hydromorphone to oral forms or vice versa, should be available on nursing units or by contacting pharmacy staff. There are smartphone apps for opioid dosing conversions, but check with the pharmacy staff to ensure accuracy before using these electronic conversion tools. Opioids are usually necessary and effective for acute pain and cancer pain of moderate or severe intensity. The goal of opioid therapy is a reduction in pain intensity to a level of acceptable comfort. In both types of pain, progress toward pain relief is measured by changes in pain intensity scores. Opioid doses often need to be adjusted up or down according to individual patient circumstances and conditions. A prescriber must carefully individualize drug selection, dosing, and schedule. Many patients are at higher risk for opioid-related adverse drug events. Box 44 to 15. Box 44 to 15. Patient characteristics associated with higher risk for opioid-related adverse drug events. Sleep apnea or sleep disordered breathing. Morbid obesity with high risk of sleep apnea. Snoring. Older age. Significant comorbidities, cardiac, pulmonary, or major organ failure. No recent opioid use. Increased opioid dose requirement. Receiving other sedating medications, example antihistamines, antipsychotics. Recent surgery, especially thoracic or upper abdominal. Prolonged general anesthesia. Smoker. Modified from the Joint Commission, According to the American Geriatric Society, AGS, 2009, opioids are probably not used enough with older people. The AGS suggests to start low, dose, and go slow, upward dose titration philosophy. Careful use of multiple drugs together can be seen as potentially helpful. Combining smaller doses of more than one medication may minimize the dose-limiting adverse effects of using a particular single drug. ACPA, 2014. The elderly require special consideration because age-related changes and increased frailty lead to less predictable drug responses, including increased drug sensitivity and severity of side effects. Van Ogic et al., 2012. Opioids may place the elderly at increased risk for falls and other injuries. Many elderly patients have multiple comorbidities and require various medications, placing them at risk for polypharmacy and drug-drug interactions. Dizziness, confusion, and changes in vision are opioid-related side effects that pose 1038 increased safety risks for the elderly. Special care must be taken to ensure that the environment is safe and patients are educated about the need for caution. Despite these concerns, elderly patients should not be deprived of opioid therapy when needed to treat pain. Carefully selected opioids and doses, along with patient education and monitoring, are important in providing safe and effective pain management. Most opioids present similar risks and benefits, but methadone, because of its long half-life, drug-drug interactions, and risk for cardiac abnormalities, is generally avoided in the elderly. Van Ogic et al., 2012. TJC requires healthcare agencies, where permissible, to have range order policies in place to guide nurses in selecting the most appropriate dose of a medication. Range orders are medication orders in which the dose varies over a prescribed range depending on the situation or a patient's status. Drew et al., 2013. Range orders enable needed and safe adjustments in doses on the basis of individual patient responses to treatment. Drew et al., 2013. However, improperly written orders can lead to problems in pain management and patient safety. Review the following order: administer 5 to 10 mg morphine sulfate IVPQ3-HPRN for acute pain. Such an order is dangerous when there are no clinical guidelines to use for selecting the exact dose. Follow these guidelines from the ISM. Drew et al., 2013. Avoid administration of partial doses at more frequent intervals so as to not underdose a patient with small, frequent, ineffective doses from within a range. Example, giving oxycodone 10 mg Q2H when the order reads oxycodone 10 to 20 mg Q3-HPRN. Avoid making a patient wait a full-time interval after giving a partial dose within the allowed range. Wait until peak effect of the first dose has been reached before giving a subsequent dose. A proper range order offers specifics for when a range of doses can be given and gives nurses the flexibility needed to treat patients' pain in a timely way while allowing for differences in patient response to pain and analgesia. Safe and effective range orders consider the patient's age, pain intensity, and comorbidities and prescribe a maximum dose that is at least 2 times but not more than 4 times the minimum dose in the range. Drew et al., 2013, Passero and McCaffrey, 2011. Co-analgesics or adjuvants are drugs originally developed to treat conditions other than pain but also have analgesic properties. For example, tricyclic antidepressants, example nortriptyline pamela, anticonvulsants, example gabapentin neurondin, and infusional lidocaine successfully treat chronic pain, especially neuropathic pain. Corticosteroids relieve the pain from inflammation and bone metastasis. Other examples of co-analgesics are bisphosphonates and calcitonin for bone pain. Passero and McCaffrey, 2011. Adjuvants have analgesic properties, enhance pain control, or relieve other symptoms associated with neuropathic pain. You give adjuvants alone or with analgesics. Sedatives, anti-anxiety agents, and muscle relaxants have no analgesic effect, although they may be effective for their specific indications. Patient-controlled analgesia. When patients depend on nurses for PRN analgesia, an erratic cycle of alternating pain and analgesia often occurs. A patient feels pain and asks for medication, but the patient first must be assessed, and then the medication must be obtained and prepared. Under this circumstance, analgesia finally occurs in about an hour, but pain relief may last only 30 minutes. Gradually the patient again feels discomfort, and the cycle begins again. The patient is constantly going in and out of analgesic therapeutic range. A drug delivery system called patient-controlled analgesia, PCA, is a method for pain management that many patients prefer. See Skill 44-1 on pages 1046 to 1049. It is a drug delivery system that allows patients to self-administer opioids, usually morphine, hydromorphone, or fentanyl, with minimal risk of overdose. The goal is to maintain a constant plasma level of analgesic to avoid the problems of PRN dosing. Systemic PCA traditionally involves 4 or subcutaneous drug administration. However, a controlled analgesia device for oral medications is available. This device allows patients access to their own oral PRN mediations, including opioids and other analgesics, antiemetics, and anxiolytics, at the bedside. Pca infusion pumps are portable and computerized and contain a chamber for a syringe or bag that delivers a small, preset dose of opioid, figure 44-12. To receive a demand dose, a patient pushes a button attached to the PCA device. The Pca infusion pumps are designed to deliver a specific dose, which is programmed to be available at specific time intervals, usually in the range of 8 to 15 minutes, when the patient activates the delivery button. A limit on the number of doses per hour or a 4-hour interval may also be set. Most pumps have lock safety systems that prevent tampering by patients or family members and are generally safe to be managed in the home. For opioid-tolerant patients such as those with cancer pain, a low-dose continuous infusion, basal rate, is sometimes programmed to deliver a steady dose of continuous medication. Paciro and McCaffrey, 2011. Figure 44-12 patient-controlled analgesia pump with cassette. Courtesy Smith's Medical ASD Incorporated, St. Paul, MN. There are many benefits to PCA use. The patient gains control over pain, and pain relief does not depend on nurse availability. Patients also have access to medication when they need it. This decreases anxiety and leads to decreased medication use. Small doses of medications are delivered at short intervals, stabilizing serum drug concentrations for sustained pain relief. Patient preparation and teaching are critical to the safe and effective use of PCA devices. Box 44-16. A patient needs to understand PCA and be physically able to locate and press the button to deliver a dose. Family members and visitors must be instructed not to push the button for the patient, a dangerous action known as PCA by proxy, 1039, as this bypasses the safety feature of PCA, which requires an awake patient to activate the device. In particular situations, when patients are unable to activate the PCA device, a carefully selected family member or nurse may be authorized to activate the device based on specific criteria. The authorized agent, controlled analgesia, AACA, guidelines should be used to guide this practice when appropriate. CUNY et al., 2013. Box 44-16. Patient teaching. Patient-controlled analgesia. Objective. Patient will achieve pain control with proper use of the patient-controlled analgesia, PCA, device. Teaching strategies. Teach how to use the PCA before procedures so patient understands how to use it after awakening from anesthesia or sedation. Reinforce as needed with teach back. Instruct patient in the purpose of PCA, emphasizing that patient controls medication delivery. Explain that the pump reduces risk of overdose. Tell family members or friends not to operate the PCA device for patient. Evaluation. Ask patient to tell you the purpose of the PCA device and when the button should be activated. Observe patient administering a dose. Evaluate the severity of patient's pain while using the PCA device. An established and properly functioning 4-catheter is needed for 4-PCA. Check the 4-line and PCA device per institutional policy to ensure proper functioning. See Chapter 42. Programming of settings usually requires independent verification by 2 nurses to ensure accuracy. Even though patients control administration of analgesics, a nurse's diligence is needed to prevent errors related to programmable PCA devices. In opioid-naive patients, do not increase demand or basal dose and shorten the interval time simultaneously because this increases the risk for oversedation and respiratory depression. Document drug dosages and track medication waste according to agency policy. Paciro and McCaffrey, 2011. PCA basal doses are not recommended for opioid-naive patients following surgery because of the possibility for respiratory depression. Topical analgesics. Topical analgesics include prescription and OTC creams, ointments, and patches that are applied to a painful area. Commonly used topical agents include NSAID products, ketoprofen patch, and capsaicin. Paciro and McCaffrey, 2011. Other topical analgesics contain local anesthetics. Products such as Elamax/LMX and eutectic mixture of local anesthetics, EMLA, are available for children. Apply EMLA via a disc or thick cream to the skin 30 to 60 minutes before minor procedures, example forestart, intramuscular injection, or anesthetic infiltration of soft tissue. Do not place EMLA around the eyes, the tympanic membrane, or over large skin surfaces. The Lidoderm patch is a topical analgesic effective for cutaneous neuropathic pain such as postherpetic neuralgia in adults. Place 3 patches, cut to size, on and around the pain side using a 12-hour on, 12-hour off schedule, Pacero and McCaffrey, 2011. Local anesthesia. Local anesthesia is the local infiltration of an anesthetic medication to induce loss of sensation to a body part. Healthcare providers often use local anesthesia during brief surgical procedures such as removing a skin lesion or suturing a wound by applying local anesthetics topically on skin and mucous membranes or injecting them subcutaneously or intradermally to anesthetize a body part. Regional anesthesia is the injection or infusion of local anesthetics to block a group of sensory nerve fibers. The anesthetics produce temporary loss of sensation by inhibiting nerve conduction. Local anesthetics also block motor and autonomic functions, depending on the amount used and the location and depth of administration. Smaller sensory nerve fibers are more sensitive to local anesthetics than are large motor fibers. As a result, the patient loses sensation before losing motor function, and conversely motor activity returns before sensation. Perineural local anesthetic infusion. A type of regional anesthesia is the use of perineural injections and infusions of local anesthetic agents to relieve pain. This technique is used for a variety of inpatient and outpatient adult and pediatric surgical procedures. A surgeon places the tip of an unsutured catheter near a nerve or groups of nerves, and the catheter exits from the surgical wound. Infusions of local anesthetics, bupivacaine or ropivacaine, may be run on a pump similar to those used for infusions, on ambulatory pumps, or on disposable systems, example on Q. The pump may be set on demand or continuous mode, and the catheter is usually left in place for 48 hours. Some patients have pump systems that are left in place even after discharge. Patients learn how to discontinue the pump at home and bring the catheter to the next healthcare provider visit. Some patients still need oral analgesics, but perineural infusions often reduce the total dosage, Pacero and McCaffrey, 2011. Local anesthetics cause side effects, depending on their absorption into the circulation. Pruritus or burning of the skin or a localized rash is common after topical applications. Application to vascular mucous membranes increases the chance of systemic effects such as a change in heart rate. The use of local anesthetics in peripheral nerve and epidural infusions, see following paragraph, may block both motor nerves and sensory nerves. This effect resolves within hours of the reduction or discontinuation of an infusion. Epidural Analgesia. Another pain therapy that often involves the administration of anesthetic agents is epidural analgesia, a form of regional anesthesia. Preservative-free opioids are often administered as single agents or in combination with local anesthetics into a patient's epidural space. Epidural analgesia effectively treats acute postoperative pain, rib fracture pain, labor and delivery pain, and chronic cancer pain. Research has shown that adults having surgery under general anesthesia experience fewer postoperative cardiovascular, respiratory, and gastrointestinal complications when receiving epidural analgesia compared with patients receiving systemic analgesia. For analgesics, popping et.al., 2014. Epidural analgesia controls or reduces severe pain and reduces a patient's overall opioid requirement, thus minimizing adverse effects. It is short or long-term, depending on a patient's condition and life expectancy. The healthcare provider administers epidural analgesia into the spinal epidural space, figure 44-13, by inserting a blunt tip needle into the level of the vertebral interspace nearest to the area requiring analgesia. He or she advances the catheter into the epidural space, removes the needle, and secures the remainder of the catheter with a dressing while ensuring that the catheter is taped securely. The end of the catheter is capped or, if a continuous infusion is prescribed, it is connected to special tubing and an infusion pump that is designated for epidural infusion. Nurse anesthetists, anesthesiologists, and certified nurses control epidural analgesia, depending on agency policy. Some patients are able to use a technique known as patient-controlled epidural analgesia, PCEA, which allows them to self-administer demand doses of epidural solution when connected to a special administration pump, Pacero and McCaffrey, 2011. Figure 44-13 anatomical drawing of epidural space. 1040. One of the concerns related to the use of peripheral and epidural anesthetic techniques is the risk of bleeding and subsequent hematoma formation near the injection/insertion site. Although relatively uncommon, the risk is increased when patients receive anticoagulant or antiplatelet medications. Safe placement or removal of these injections and catheters is made on the basis of knowledge of the patient's coagulation status and the timing of administration of anticoagulant or antiplatelet medications. Guidelines for the use of anticoagulation in patients with regional anesthesia are available, NARAS et.al., 2015. Because the epidural space is a highly vascular area, patients with epidural catheters are at risk for the development of epidural hematomas, which may lead to ischemia of the spinal cord, and if unaddressed, serious neurological complications. Complications. Nursing implications for local and regional anesthesia. Provide emotional support to patients receiving local or regional anesthesia by explaining the insertion technique and warning patients that they will temporarily lose sensory function within minutes of injection. Motor and autonomic. bowel and bladder control, function may also be lost quickly, depending on the area anesthetized. It is common for patients to fear paralysis because epidural and spinal injections come close to the spinal cord. To reassure the patient, explain that numbness, tingling, and coldness are common. Catheter insertion should be comfortable because the healthcare provider should first numb the injection site. Prepare patients for possible discomfort. Before a patient receives an analgesic, check for allergies. Also check to be sure that the drugs, example morphine Duramorph and fentanyl sublimase, administered via the epidural catheter are free of potentially neurotoxic substances such as preservatives and additives. Assess vital signs to monitor systemic effects. After administration of a local or regional anesthetic, protect the patient from injury until full sensory and motor function return. Patients are at risk for injuring an anesthetized body part without knowing it. For patients with topical anesthesia, avoid applying heat or cold to numb areas. After an injection into the knee joint, warn the patient to avoid standing without assistance because there is a high risk of falling. With peripheral nerve or epidural local anesthetics, patients may experience sensory loss along with significant motor weakness. Assess patients for sensory and motor nerve blockade and notify the prescriber when motor blockade is unintended. Protect patients from injury and educate about necessary precautions until full sensory and motor function return. During and after epidural anesthesia, a patient stays in bed until motor function returns. Help the patient the first time he or she tries to get out of bed. When managing epidural infusions, if agency policy allows, connect the catheter to an infusion pump, a port, or a reservoir or cap it off for bolus injections. To reduce the risk of accidental epidural injection of drugs intended for use, clearly label the catheter epidural catheter. Always administer continuous infusions through appropriately labeled electronic infusion devices for proper control. Because of the catheter location, use surgical asepsis to prevent a serious and potentially fatal infection. Notify a patient's healthcare provider immediately of any signs or symptoms of infection or pain at the insertion site. Thorough hygiene is necessary during nursing procedures to keep the catheter system clean and dry. Maintain a closed system and prevent catheter disconnection by ensuring tight connections. Nursing implications for managing epidural analgesia are numerous. Table 44-6. Do not administer supplemental doses of opioids or 1041 sedatives/hypnotics because of possible additive central nervous system adverse effects. Monitoring for effects of medications differs, depending on medication used and whether infusions are intermittent or continuous. Complications of epidural opioid use include nausea and vomiting, urinary retention, constipation, respiratory depression, and pruritus. Passero and McCaffrey, 2011. When patients receive epidural analgesia, initially monitor them as often as every 15 minutes, including assessment of vital signs, respiratory effort, and skin color. Once stabilized, monitoring occurs every hour in the first 12 to 24 hours and then with less frequency if the patient is stable. Refer to agency policy. Table 44-6. Nursing care for patients with epidural infusions. Goal. Actions. Prevent catheter displacement. Secure catheter, if not connected to implanted reservoir, carefully to outside skin. Maintain catheter function. Check external dressing around catheter site for dampness or discharge. Leakage of epidural solution may occur if catheter is dislodged. Use transparent dressing to secure catheter and aid inspection. Inspect catheter for breaks. Prevent infection. Use strict aseptic technique when caring for catheter, see Chapter 29. Do not change dressing routinely oversight. Inspect insertion site for signs of infection. Follow institutional policies for tubing change. Monitor for respiratory depression. Monitor vital signs, especially respirations, per policy. Use pulse oximetry, end-tidal carbon dioxide, and apnea monitoring. Prevent undesirable complications. Assess for hemodynamic changes associated with use of local anesthetics that may cause vasodilation and subsequent hypotension. Ensure adequate hydration and administer prescribed intravenous fluids. Notify prescriber if significant change in vital signs occurs and reduce or stop epidural infusion. Anticipate need for change in epidural solution. Assess for pruritus, itching, and nausea and vomiting associated with use of epidural opioids. Notify prescriber for dose reduction or epidural solution change. Administer antihistamines and antiemetics as ordered. Assess sensation and motor strength. Notify health provider if deviation from baseline. Maintain urinary and bowel function. Monitor intake and output. Assess for bladder and bowel distension. Assess for discomfort, frequency, and urgency. To minimize bleeding risks and the potential for hematoma formation, anticoagulant and antiplatelet medications should not be administered until a pain specialist can verify safe use. To detect development of a possible epidural hematoma, notify the healthcare provider or pain specialist if the patient develops severe pain at the epidural insertion site or unexplained sensory or motor loss. The provider who performs the procedure should also be notified when patients with peripheral nerve injection/catheter have similar signs and symptoms. The patient needs to receive thorough education about epidural analgesia in terms of the action of the medication and its advantages and disadvantages. Instruct patients about the potential for side effects and to notify their healthcare provider if side effects develop. If the patient requires long-term epidural use, the healthcare provider tunnels a permanent catheter through the skin. The catheter exits at the patient's side. Teach a patient on long-term therapy how to safely administer home infusions with minimal ongoing nursing intervention and coordinate with the case manager or social worker to ensure that appropriate home care services will be provided. Invasive interventions for pain relief. When severe pain persists despite medical treatment, available invasive interventions include intrathecal implantable pumps or injections, spinal cord and deep brain stimulation, neuroablative procedures, cordotomy, rhizotomy, trigger point injections, cryoablation, and intraspinal medications, example opioids, steroids, local anesthetics. These techniques are useful for chronic pain. It is not acceptable to tell a patient with severe unrelieved pain that there is nothing more we can do for you. Patients with severe chronic pain should be referred to comprehensive pain management programs whenever possible. These programs offer many different interventional strategies, pharmacological options, physical medicine, and rehabilitation therapies to address the complex needs of patients with chronic pain. When comprehensive pain programs are not available, referral to a chronic pain management program may be the best available option. Procedure pain management. Diagnostic and treatment procedures potentially produce pain and anxiety, both of which should be assessed and treated before a procedure begins. Zarnecki et al., 2011. Barriers to successful pain control include numerous patient-specific factors, but perhaps more influential is the lack of acknowledgement by healthcare providers that pain may occur during or after a procedure. Without this acknowledgement, the necessary anticipation, prevention, and management of potential or actual procedural pain cannot occur. Zarnecki et al., 2011. The Thunder Project 2, Pontelo et al., 2001. Identified several procedures causing pain in critical care patients: turning, wound drain removal, tracheal suctioning, femoral catheter removal, placement of a central line, and changing of non-burn wound dressings. Common pharmacological agents for managing procedural comfort include local anesthetics, NSAIDs, acetaminophen, opioids, anxiolytics, and sedatives. Zarnecki et al., 2011. Premedicating patients before painful procedures allows them to cooperate more fully and reduces the experience of pain. Using non-pharmacological therapies such as relaxation techniques, meditation, imagery, and music, in addition to medications, has been effective in select situations. Zarnecki et al., 2011. When you premedicate a patient before a procedure, keep in mind the time to onset and time to peak effect of the analgesic to properly time the beginning of the painful procedure. Cancer pain and chronic non-cancer pain management. Cancer pain is either chronic or acute. The prevalence of pain varies among cancer patients. A review of research spanning 40 years shows the prevalence ranging from 64% in patients with metastatic, advanced, or terminal phases of the disease, 59% in patients on anti-cancer treatment, and 33% in patients after curative treatment. Van den Buchan van Evertingen et al., 2007. Experts and consensus panels agree that cancer pain is still not adequately treated. Ripamonti et al., 2011. Organizations such as the APS and the National Comprehensive Cancer Network, NCCN, have published guidelines for assessing and treating cancer-related pain. The guidelines support comprehensive and aggressive treatment, including many options for pain relief. The best choice of pain treatment often changes as a patient's condition and the characteristics of pain change. You can use non-pharmacological interventions with pharmacological interventions to optimize care. Similar recommendations are made for the treatment of pain in patients with chronic non-cancer pain. In 2009, the APS and the American Academy of Pain Medicine jointly recommended that chronic opioid therapy can be an effective therapy for carefully selected and monitored patients with chronic non-cancer pain. Joe et al., 2009. Analgesics for chronic pain should be prescribed on a regular basis and not on as required schedule. Ripamonti et al., 2011. However, chronic pain is complex and requires the careful selection of patients, identification of their risks, use of different treatments, often in combination, and ongoing monitoring to offer patients the best possible outcomes. Treatment options are continuously expanding and include a variety of pharmacological agents, physical therapies, behavioral medicine, surgical interventions, neuromodulation, complementary, and alternative approaches. Turk et al., 2011. No one approach has demonstrated superiority, and overall treatment effectiveness is poor and inconsistent. Turk et al., 2011. Patients are often desperate, frustrated, and anxious when presenting for treatment. It is important to provide emotional support and educate them about taking an active role in their pain management with realistic goals and expectations. Comorbidities such as anxiety and depression can worsen pain and require separate assessment and treatment. Many patients with cancer experience breakthrough cancer pain, BTCP, a transient worsening of pain that occurs either spontaneously or in relation to a specific predictable or unpredictable trigger, despite relatively stable and adequately controlled background pain. European Oncology Nursing Society, 2013. BTCP is a challenging aspect of cancer because, even though it is self-limiting in nature, its presence has a significant, negative impact on the quality of life of patients and family caregivers. European Oncology Nursing Society, 2013. Individualized assessment is critical for understanding how BTCP affects a patient's life. A holistic approach to care is often needed. Box 44 to 17. There is evidence for the proper treatment of breakthrough pain in cancer patients. However, there is little evidence for how to treat it in patients with chronic non-cancer pain. Manchikanti et al., 2011. Multiple issues related to the concept of breakthrough pain in chronic non-cancer pain evolve around extensive use, overuse, misuse, and abuse of opioids. In the era of eliminating opioids or significantly curtailing their use to only appropriate indications, the concept of breakthrough pain raises multiple questions without any scientific evidence. Box 44 to 17. Types of breakthrough pain and treatment. Types of breakthrough pain. Incident pain, pain that is predictable and elicited by specific behaviors or triggers such as a voluntary act, walking, involuntary act, coughing, or treatments, example wound dressing changes. End of dose failure pain, pain that occurs toward the end of the usual dosing interval of a regularly scheduled analgesic. Spontaneous pain, pain that is unpredictable and not associated with any activity or event. Treatment. Lifestyle changes. Management of reversible causes. Modification of pathological processes. Non-pharmacological management. Pharmacological management, rescue dose of medication. Interventional techniques. From Haugen D.F. et al., Assessment and Classification of Cancer Breakthrough Pain, a Systematic Literature Review, Pain 149, 3476, 2010, Europe. 1042. The APS reports that the primary goal in treating chronic non-cancer pain with opioids is to increase patients' level of function rather than just to provide pain relief, ACPA, 2014. The use of opioid therapy in patients with chronic pain requires careful patient selection and consideration of the risks and benefits of opioids. For example, to determine whether opioids are beneficial for a patient, it is necessary to assess his or her level of participation in ADLS, physical therapies, family activities, and work-related functions. Family members are often included in office visits to provide input about a patient's functional level. Research has not yet provided clear evidence to support or guide the use of chronic opioid therapy for patients with chronic non-cancer pain, Joe et al., 2015. It is recommended that each person with chronic non-cancer pain be medically managed individually. Medication use should be determined by weighing benefit compared to other alternatives, cost, potential side effects, and the person's other medical problems, ACPA, 2014. Concerns about long-term opioid use are related to loss of beneficial effect over time, increasing tolerance, and escalating use with decreasing function, ACPA, 2014. Cancer pain exemplar. The World Health Organization, WHO, in 1986 introduced the WHO three-step analgesic ladder as a recommended approach for the management of cancer pain, figure 44 to 14. This approach has been used worldwide and has been praised for its simplicity and ease of use. However, the ladder has been the object of criticism, Vargas Schaefer, 2010. The three-step approach recommends that therapy begin at the first step with the use of non-opioid analgesics and/or adjuvants and progress to the next higher step as pain intensity increases. Weak opioids alone or in combination with the non-opioid analgesics and/or adjuvants are recommended at step 2, and, if pain persists, strong opioids are recommended at step 3. There have been efforts to modify the steps to facilitate use of the latter for different pain presentations. A bidirectional approach has been suggested in which, in addition to the original step-up approach, a step-down approach would be used for patients with intense acute pain, uncontrolled cancer pain, and breakthrough pain, Pca et al., 2011. With this modification, therapy would begin at the third step with the strong opioids and descend down the ladder with improvement in pain. Another modification includes the addition of a fourth step, which recommends neurosurgical and other invasive procedures and also includes management of pediatric and acute pain in emergency departments and postoperative situations, Vargas Schaefer, 2010, figure 44 to 15. The new fourth step is recommended for the treatment of crises of chronic pain. Many other modifications of the latter have been proposed, including those that recommend the use of a multimodal approach at each level. Long-acting or controlled-release medications may provide relief for all types of chronic pain, including cancer pain. These controlled-release medications, example morphine MS-Contin, Roxanol SR, and oxycodone OxyContin, relieve pain for 8 to 12 hours. Long-acting or sustained-release opioids are dosed on a scheduled basis, not PRN, or as needed. Transdermal fentanyl, which is 100 times more potent than morphine, is available for opioid-tolerant patients with cancer or chronic pain. It delivers predetermined doses that provide analgesia for up to 72 hours. The transdermal route is useful when patients are unable to take drugs orally. Patients find the transdermal patch easy to use because it allows for continuous opioid administration without needles or pumps. Self-adhesive patches release the medication slowly over time, achieving effective analgesia. Transdermal fentanyl is not for adult patients who weigh less than 100 pounds, too little subcutaneous tissue for absorption, or who are hyperthermic, increases drug absorption. Do not place heating pads over a patch and never cut it. To dispose of a patch, fold in half, adhesive side onto itself, and flush down the toilet, Paciro and McCaffrey, 2011. All patients on chronic opioid therapy require monitoring and follow-up. Side effects should be anticipated, prevented when possible, and treated when necessary. Over time, tolerance develops to the analgesic effect of opioids, necessitating dose escalation to achieve pain relief. The higher opioid dose is usually not lethal because patients also develop a tolerance to respiratory depression. Less commonly, chronic 1043 opioid use may lead to hyperalgesia, increased pain sensitivity. Especially in the case of non-cancer pain, patients should be closely monitored for signs of aberrant opioid-related behaviors such as misuse, abuse, and addiction. A transmucosal fentanyl unit now exists to treat breakthrough pain in opioid-tolerant patients. Swab the fentanyl unit in the mouth over the buccal mucosa and gums. The unit remains intact to dissolve in the mouth, not chewed. Allow to absorb over a 15-minute period, delaying swallowing as long as possible. Use no more than 2 units per breakthrough pain episode. If the patient's pain is not relieved after 2 units, notify the patient's healthcare provider, Paciro and McCaffrey, 2011. Many patients, family members, and healthcare providers have concerns about the risks of addiction associated with opioid use. Estimates of addiction in patients with chronic persistent pain range from 6% to 10%, Paciro and McCaffrey, 2011. Often a person with chronic pain who consults with numerous healthcare providers is labeled a drug seeker, when he or she is actually seeking adequate pain relief. This situation may be associated with behaviors that are indicative of pseudo-addiction. Nurses need to discourage patients from doctor shopping and having multiple healthcare providers for treating pain and refer them to pain specialists. Pain centers offer a holistic approach to chronic pain, using both non-pharmacological and pharmacological strategies for chronic pain management, Paciro and McCaffrey, 2011. As with constant acute pain, it is necessary to give patients with chronic pain required analgesics on a regular basis. The oral route of administration of analgesic drugs should be advocated as the first choice, Ripamonti et al., 2011. Prescribing analgesics on a PRN basis for chronic pain is ineffective and causes more suffering. The patient with chronic pain needs to take an analgesic ATC, even when the pain subsides. Regular administration maintains therapeutic drug blood levels for ongoing pain control. Administer analgesics rectally when patients are unable to swallow, have nausea or vomiting, or are near death. This route is contraindicated for patients with diarrhea or cancerous lesions involving the anus or rectum. Morphine, hydromorphone, and oxymorphone are available in suppositories, Paciro and McCaffrey, 2011. Some patients use Pca devices to treat severe cancer pain in the home. Pca devices provide improved, uniform pain control with fewer peaks and valleys in plasma concentration, more effective drug action, and lower drug dosages overall. Patients who usually benefit from continuous infusions include those with severe pain for whom oral and injectable medications provide minimal relief, those with severe nausea and vomiting, and those unable to swallow oral medications. When a patient first receives continuous drip opioids, the 4-axis needs to be patent and without complications, see Chapter 42. A central venous catheter, an implanted venous access port, or a peripherally inserted central catheter is usually best for long-term 4 infusion. When 4-axis is poor, the subcutaneous route with a concentrated dose is possible. When an infusion begins, monitor a patient's sedation level and respiratory status closely during the first 24 hours, and with any increases in the infusion rate, follow agency policy. Patients who are placed on continuous analgesic infusions are opioid tolerant, thus respiratory depression is rare. QSEN. Barriers to Box 44. Patients and healthcare providers often do not understand the differences among physical dependence, addiction, and drug tolerance. Box 44 to 19. Definitions related to the use of opioids in pain treatment *. Physical dependence. A state of adaptation that is manifested by a drug class, specific withdrawal syndrome produced by abrupt cessation, rapid dose reduction, decreasing blood level of the drug, and/or administration of an antagonist. Common symptoms of opioid withdrawal include shaking, chills, abdominal cramps, excessive yawning, and joint pain. Addiction. A primary, chronic, neurobiological disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. Addictive behaviors include one or more of the following: impaired control over drug use, compulsive use, continued use despite harm, and craving. Drug tolerance. A state of adaptation in which exposure to a drug induces changes that result in a diminution of one or more effects of the drug over time. Approved by the boards of directors of the American Academy of Pain Medicine, the American Pain Society, and the American Society of Addiction Medicine, February 2001, American Pain Society, 2011. Placebos. There are many different definitions and interpretations of the terms placebo and placebo effect. It is generally accepted that placebos are pharmacologically inactive preparations or procedures that produce no beneficial or therapeutic effect. Professional organizations discourage the use of placebos to treat pain. It is considered unethical and deceitful to administer them. Placebo use jeopardizes the trust between patients and their caregivers. If a placebo is ordered, question the order. Many healthcare agencies have policies that limit the use of placebos to research only. Passero and McCaffrey, 2011. Restorative and continuing care. Pain clinics, palliative care, and hospices. Health professionals recognize pain as a significant health problem. Growth of pain centers, palliative care departments, and hospices designed to manage pain and suffering has increased. The Commission on Accreditation of Rehabilitation Facilities, CARF, accredits chronic pain treatment programs and sets standards for chronic pain management. A 1045 comprehensive pain center treats people on an inpatient or outpatient basis. Staff members representing all healthcare disciplines